We're going to talk about back pain, and what Julia said about my interest in patient education and dealing with family doctors is absolutely true. I think the essential element in managing back pain is to put the burden back on you. You cannot expect someone else to do it for you. You have to be able to manage back pain in your practice. The majority of times it's successful, it's not difficult, but it does require a change in thinking, in an approach that works, that's easy, that's practical, that's something you can do, that you can start doing tomorrow morning and make a difference in the way your patients are managed. The mechanical patterns are not difficult. We'll discuss them. But the mechanical patterns actually stand behind a different approach, a different philosophy, a different way of thinking about back pain. And whether or not you're comfortable with the patterns at the end of the morning, whether you can separate a pattern 1 from a pattern 2, is actually less important than your ability to listen to someone with back pain and say, I understand this problem, I recognize it as a benign mechanical situation, and then offer them some type of practical help to get them better. So this is the approach that we want you to take. This is the way we're dealing with this. And it's going to begin by talking about this syndrome approach to back pain. I have my disclaimers, which the college makes sure I tell you. So this is who I am, and that's the people I work with. There's no support from the thing for this. And the conflict of interest is that I'm going to be talking about the patterns of pain, which I developed. So it's a conflict. I'm here to tell you what I think you should do. If you haven't figured that out yet, we'll go slowly. And the fact that CBI has been part of this ever since this thing. This pattern system now is over 40 years old. This is not new news. This is something that we have been evolving and working on for 4 decades to try and make it work. And the more we do this, the simpler it gets. It's fascinating. I look back at where we were way back then, and it was very complicated, and we were arguing. Every time we review it, we make it easier. Easier in a sense that it's simpler, but that doesn't make it easier to deliver. You've got to get it right. So let's begin at the beginning. You've heard this, and I'm not going to spend a long time with it because we don't have a lot of time this morning, but you know that it isn't working the way it's doing it now. There's a recent article in JAMA. If you haven't seen this, it's worth digging it up, looking at the fact that we don't follow guidelines. This was over January 99 to 2010, looking at some 23,000 visits and looking at the way we do what the guidelines say we shouldn't do. For example, MRI usage has increased. We're all saying don't use MRI, but we keep on doing it, we keep on ordering it. This is the Ontario experience, and if the dark gray line is just spine. And that's what's happened to the MRI usage for spine. In spite of the fact we're saying it's wrong, people keep doing it. We know that NSAID use is going down and narcotic use is going up. And there are a few things about this, and there's one I'll say this now and I'll say it over and over. I do not believe there is any role for narcotic use in a back-dominant mechanical patient. None. I don't care how bad the pain's really bad. Well, that's irrelevant. There is no use for narcotics in mechanical back-dominant pain. And if you're doing it, it's because you don't know what else to do, and we've got to change that. Specialist referrals keep going up. And this was a paper published in Ottawa by Eugene Way, and what he showed was that the specialist referrals are less than 30%. The number is actually closer to 20% that actually require surgery. That most patients that come to see spine surgeons and that come to see me as a spine surgeon don't come because they have surgery. They come because somebody said, I don't know what to do, go see a surgeon. And what does the surgeon say? He says, you don't need surgery, I can't help you, go back and see the person that sent you, and the patients are totally confused and lost. Back pain, as you've just heard, is a huge social burden. There are all kinds of people out there doing all kinds of things. It doesn't matter, you go to a different specialist, you get a different approach, and everybody's got their own, and that's why the conflicts are so common. It is the commonest cause of recurrent lost time, and in the United States at least, it's now a $100 billion loss a year. Enormous amounts of money. There's no correlation between plain X-ray and back pain. None. This is something that we know, and we keep ordering them anyway. You take an x-ray, oh look, it's got very bad degenerative disease. Well, so what? There's no correlation between the image you see and how much pain they have. CAT scans carry a 30% false positive, and the biggie is MRI, which carries up to 90%, in the newest Ontario study, false positive. Everybody with an MRI has a pathology. It's irrelevant to the pain, has nothing to do with the symptomatology, but there's something there. And we now know, and this is a brand new study which is just saying what we've been saying for years, this is just in Spine last month, that early MRI without indication, we're not talking about using an MRI if you suspect a tumor, but taking an MRI because I don't know what it is, let's get a picture and see, actually creates a worse outcome. People do worse if you order the test than if you don't do it. So we're doing this wrong, and it's actually going in the wrong direction. We know with all our technology that we can make the diagnosis in mechanical back pain in about 20% of cases, and that 20% is predominantly the leg-dominant patient. So when we deal only with the back-dominant, the number's even worse. We just don't know where the pain comes from. Now, that doesn't mean we don't understand back pain. And it doesn't mean I can't tell you that there is the disc that hurts and the facets that hurt. And I get that. What I'm saying is if you come to me and say, my back hurts, I have about a 20% chance of being able to say it's caused by X, and the rest of the time I just can't tell. So what happens in this circumstance? It gets labeled as non-specific back pain. If you want to get me going, and I'll stay up here for hours, just tell me you've got a case of non-specific back pain. It drives me absolutely up a wall. Nowhere else in medicine do we get away with this. Tomorrow in Alberta, I'm giving a lecture on non-specific chest pain. I'm sure you'll all want to come and hear it, because we're going to talk about non-specific chest pain treated non-specifically. And then you wonder, well, how can you do this in backs? I mean, everywhere else in medicine, we laugh at it. But in backs, oh, yeah, non-specific back pain, which, of course, is treated non-specifically, which doesn't work. And so patients are left not knowing what's going on, and we're left as the healthcare providers, in the first instance, saying, I don't know what to do. I better send you somewhere else. We don't give the patients what the patients want. What do they want? What do they come to see you for? They come because they're in pain, and they want their pain to stop. It's that simple. All they want you to do is make the pain go away. So they go and they see a manual therapist, a chiropractor, and in a significant percentage, the acute pain stops. And they come out feeling better than they did when they went in, and there's nothing wrong with that. What's wrong is what happens next, which is told, well, that's because something's out of place and it slipped back in and it's going to slip back out, so you better see me once a month for the rest of your life, and that is where we go off the rails. But mechanical therapy for mechanical problems makes perfect sense. But as physicians, we're not comfortable with that. That's not a world we live in, and it's a world we need to get into and do it right. So the immediate pain relief is essential. They need reassurance. They need you to look them in the eye and say, I know what this is, and you're going to be okay. How many people in this room are comfortable in that world? That little voice in the back of your head, the one you've lived with all your practice life, the one that says, oh, you're over your head in this one, all right? Basically, we've got to change our attitude. I had a young doctor who sat through one of my lectures and came up at the end, and he said, well, I've got a slip disc. You're a doctor, for crying out loud, and you believe you've got a slip disc. No wonder your patients don't do well. You're more frightened of it than they are. They need a prognosis. They need to know what's going to happen, and ultimately, and this is critical, they need a sense of control. They need to know what to do to feel better. And Julia's mentioned this green light to go back to work. We've got to give them that green light. And we can't give it to them if we're so afraid that something's going on that we don't understand. So we need to deal with the problem differently. The current approach doesn't work because it's the wrong approach. Back pain is not a medical condition. In most cases, back pain is not the result of a tumor, a trauma, an infection, or any medical problem whatsoever. The statistic here is over 90%. And this number holds, and it's sliced and diced all sorts of different ways, but it comes out the same every time. roughly 9 out of 10 of the backs you will see in your practice do not have a specific illness, trauma, or anything else medical. And most back pain, surprisingly, just begins. We published this study back in 1999. 11,000 patients in the study, and what we found was that for those that didn't need to claim comp or weren't suing somebody, 2/3, 67%, actually 67.2% in the study, could not recall any event that triggered their pain. And we gave them absolute license to tell us anything they wanted, and we accepted that. There wasn't an argument. We just said, yeah, okay, that's the reason. And still, 2/3 said, I don't know. Now go back to your conversation with back pain. Well, what did you do? I'm not sure. Well, you must have done something. I'm not sure. Well, think harder. And of course, they come up then with something. Well, when I was 12 years old, I slipped. And right away, what have you done? You've created this image of the back as fragile, that, oh my God, it happened the last time. If you do it again, you could be paralyzed. And so you've left them with a message you didn't intend because you didn't approach it correctly. And still we do the red flags. It's right up there, green dots. Got to know the red flags. Okay, well, if you want them, here they are. I'll give them to you. You'll have to write these down quickly. This is out of a large neurology textbook, 3-volume book, and so this is a great list of all the potential red flags. And I will submit to you this is the wrong way to begin to treat back pain. What this system does, in effect, is turn everything upside down. Instead of saying, let's remember everything that it could possibly be and then weed through it, let's do it the other way around. Let's go to where the action is. Let's sort out the mechanicals first, and if that doesn't work, then let's go back and start thinking red flags. It's a different way to approach it. 90% is caused by minor mechanics. I've told you that. Most back pain is mechanical. And so that's where I think we begin. Now, before we go further, I've got to make it clear what is mechanical pain. If I say to you this person has mechanical back pain, I know what I'm thinking. What do you hear? Well, mechanical pain is pain that's related to movement. First and foremost, it's pain that's worse if that hurts, that doesn't hurt so much. That's a mechanical story. It's not an inflammatory story. It's a mechanical story. It's pain that's related to position. It's pain that says, when I sit in a slumped position, 2 hours like this and my back is killing me, so what do? I get up and that feels better. That's a mechanical story. It is pain that is related to a specific physical structure, a single element or elements in the spine that are causing the pain. Now, my problem is that in the individual case, I can't tell you what the element is. I don't know. I can't be sure if it's the disc or the joint or whatever, but I know it's there and I know it's mechanical. So I use a technical term to cover this. It's a sore thing. That's an orthopedic term. We use that a lot. Orthopedic surgeons do that a lot, just pound the daylights out of that thing. So basically, if you accept the fact that it's a sore thing, then we've got a point of agreement. We talked earlier, we were just sitting at the table talking about some research that's done, and people are so highly suggestible, and there was a discussion about a little research experiment where there were 2 jars of yogurt, and they were asked to choose which one was more strawberry-like, and it turned out neither one was strawberry at all. But everybody kept picking one or the other because they were primed for that. We need to step back from the areas where we can't agree and stop at the one place that I think we can agree, that this person's history is mechanical. And that's really all it has to be. It's mechanical pain because it's related to movement, it's related to position, it's got some specific characteristics, and we can agree that it's mechanical. We can't agree then on what the mechanical thing is. There we get into trouble. And the neat thing about this, and this is the thing you must remember, is that in family medicine, in primary care, if you're not going to be invasive, you don't need to know. Now, this is such a simple step in my mind, and I have such trouble selling it to the young doctors and the young physical therapists who just don't want to hear me. No, I've spent all these years learning pathology. I've got to know. Well, you can't know. 80% of the time, you don't know. But what you do know is that there's a pattern here, a mechanical pattern that is recognizable and is in turn treatable. And that's where it begins. This is not the end of the road, this is the first step in the road. This doesn't cure back pain. This gives you a place to start that makes sense and from which you can develop a very comprehensive strategy for recovering the mechanical problem and then in turn returning them to work and to function.